welcome Dr. Ranjan Shetty to get started with the introduction of his. And as we join, we will invite the discussion.
Good evening. Thank you, Dr. Mathur, and thank you, CVT India, for giving me this opportunity to give a talk here. And I'm really, the team of experts you have put in is really great, and it's actually a great honor to be presenting in such a forum. Thank you, Dr. Mathur. So as you have outlined the way we are going to discuss, I think I'll put on the case first, and then we can have experts talking about the case, and then I'll slowly go on with the procedure with the emphasis on each step on how to do it. So this is the case. I hope all of you can see my slide.
Yeah,
and
your slides are well visible and you're very clearly audible.
Okay. Thank you, Dr. Mathur. So this is a 78-year-old gentleman who is diabetic, who also had history of old MI, who had undergone angioplasty. He has CKD, but creatinine is around 2. It's not too bad. He had persistent AF, also history of recurrent pre-syncope. There's never been a fall. It's more of pre-syncope. And he had history of intracranial hemorrhage on OAC, which was managed conservatively. And then he comes to us, and at this point, we are thinking of managing him. So I'll open this case to our panel of experts, and so I have two questions for them. One is, how would they manage this case, and what has been their indication? I mean, it's not a exam and it's not an MCQ question. Answer is already out.
Yeah.
So it's more just about what are the indications in their center for LAA closure. I would like to hear from them about what are the kind of people they offer this therapy.
Yeah, sure. So shall we start with Dr. Hazra? Hazra, would you like to make a comment on indications?
Yes. Right candidate for LAA closure because he has bled. He's elderly with a recurrent fall. And once he bleeds, that means he's going to bleed almost frequently in his lifetime as long as he lives. So definitely LAA closure.
Yes. And what are your indication, Dr. Hazra, in yours? I mean, this is just for people who are starting the, program in their center.
These are basically contraindications to your oral anticoagulants. That's the only one thing. And have a history of bleed on oral anticoagulant. Over.
Okay. So,
Dr. Sahil, would you like to make a comment on how you are looking at it in the US?
Yeah, so the only issue with the Watchman device is that for the patients, there's no discernible immediate benefit. When you do stents or TAVRs, patients feel really good. So the key is here to avoid absolute complications. That could be perforation, groin complications. So patients do not really value this procedure till they're able to prevent a stroke. So anytime your CHADS VASC is more than 3 and your patient has some issues where that precludes anticoagulation. Now, if you look at the FDA guidelines, they say they should still be candidates for Coumadin. If we all look at it, but we all work around it. So most of these patients are absolute contraindicated or have strong relative contraindications for the very high risk of stroke. And the key is, you will find a lot of population, patients in your practice that will be Watchman candidates, quote unquote. But if they don't have a high CHADS VASC risk, then I would not do it because the patients do not feel immediate benefits of this procedure. It's more so for a prevention of stroke. What do you think about that?
Yeah, that's a very right thing. There is no immediate difference which a patient notices, and even later on in the long term, you keep wondering whether he's satisfied with your implantation because there's nothing changed except that you've reduced his risk.
What about Kira? What about the prevention of OAC? You're talking about prevention of stroke. What is the role of LAA closure for the prevention of OAC? For warfarin or Coumadin in each case?
Yeah.
Prevention of, sorry?
Oral anticoagulant.
Oh yeah, absolutely. I mean, if I didn't understand your question, so you're saying, can you repeat your question again?
So I think,
yeah.
Go ahead.
So what Dr. Hazra means is, do you think the oral anticoagulation that is usually offered at this age to a lot of people, is it adequate in stroke? Are we giving the right dosages?
No. I'm saying,
would that be
Dr.
justified?
What I'm saying, can we avoid oral anticoagulant and coumadin for lifelong by one-time procedure like LA closure in him? You are saying you are going to prevent stroke, which is not very encouraging for him. But is it encouraging for him to stop OAC in his lifetime?
Yeah, absolutely. I think that's a great point, because see, if you follow these patients for 10, 15, and most of these patients actually end up living very long, and it's not about right now, they might have a fall after 5 years or 6 years. And absolutely, that makes a point where you can minimize your risk of use of antiplatelets, in this case, with anticoagulation, and especially if you're using novel agents. Especially in older patients, you can have disastrous complications. But that said, my key point is that, you know, your CHADS VAS should be high for you to be pushing for these procedures, is what I'm trying to get to. Because nowadays with most PCIs, you can get away with 1 to 3 months of dual antiplatelet, and you can just go to a single antiplatelet therapy. So plus one of the anticoagulants. So I do understand that's a great point, but sometimes it's very hard to explain to patients.
Any other experts who want to?
We can request Dr. Manik Chopra and Dr. Bhupati also to make a comment. In this time. So Dr. Bhupati, what is your take on the what should be the threshold to use a LA appendage closure device, keeping in mind the cost in our country and how many patients are suitable for it?
So I personally feel it's a wonderful therapy. Unfortunately, it's underutilized here because of the cost involved in it. As our country's economy goes by, if we have some other indigenously made devices like what we have in TAVR system, I think this therapy will be highly utilized.
Great. And Dr. Manik, are you unmuted? We'll take one more comment and then we.
Yeah, so I think the most common indication would be probably if the anticoagulant therapy is contraindicated. That is what I understand. Second would be if it is intolerant. That is the second thing. Third thing is it is ineffective. That means despite giving a lot of anticoagulants, still the patient is getting stroke, then probably it can be add-on. And the fourth thing, which is really very controversial, is something like a young man who is like 40, 45, who becomes a candidate for oral anticoagulants and refuses to take anticoagulants and wants to live a really active life. Something like he wants to ski and he wants to do things like those, which can be really, leading to a lot of trauma. And they want to live an active life without OAC or probably NOVAC. So these are four things: contraindications, side effects, intolerance, and probably refusal for the therapy. And that's what I presume is the way to go.
So another issue is a lot of our rheumatic heart disease patients have atrial fibrillation, and we don't have much evaluation data-wise on these patients. But what is your opinion, and why do they differ from the lone AF and other chronic AF patients? Dr. Hazra and Dr. Ranjan, and then Dr. Sahil.
Dr. Hazra, would you like to answer that?
Go ahead.
Rheumatic AF and anticoagulation.
I think,
LAA basically.
LAA.
Yeah.
In rheumatic, if you have a significant gradient, you should not try this device. It should be put on warfarin. But there is a trial now. Even in rheumatic, you can prescribe NOAC. The problem is, in our country, the target to therapeutic range is very poor. So that is one of the reasons. Most of these rheumatics are far away from the city, and they are from the rural areas. They don't come for TTR or INR follow-up. So if it is mild MS, okay, fine, you still can go ahead with the LA closure if there is a contraindication to oral anticoagulation.
So if a mild MS develops atrial fibrillation and he cannot be given oral anticoagulation due to some contraindication of IC bleed, would you consider LA appendage closure in that case?
Yes.
That would be a good indication, Dr. Mathur. But as such, it is never a first choice. It's not an alternative to anticoagulation as we are discussing, because there it is believed that the clot could be actually anywhere. It need not be in the appendage. It's in appendage in 60% cases, whereas if you look at non-valvular AF, the clot is predominantly in appendage. So appendage exclusion probably makes sense. But here, I think valvular AF, we have to be a little careful about the definition. The definition of valvular AF is only MS and prosthetic valve. So if it is MR, HCM, AS, AR, so with TAVI, it's okay to do it because the problem is in aortic valve. The problem, if it is in mitral valve, that to MS, more than moderate MS and prosthetic valve. These are the things which are probably considered as valvular AF. Partly because the international trials, when the rivaroxaban trials and the apixaban trials actually included around 20% patients who had MR and AF and who had AS and AF, and they didn't classify them as valvular AF. They did classify them as non-valvular AF. So we're not sure whether this works. We don't even give NOACs to these patients. It's obviously, if it is a prosthetic valve, dabigatran trial showed that it doesn't work very well. But whether we can give it for other rheumatic AF, we are not really sure. So these are some areas which still need some more data.
Another problem is if you have a significant MS on medical therapy, if you bleed, I mean, if you have this watchman, if they bleed, because of the high LA pressure, the chance of pericardial tamponade is also very high.
Correct.
Okay, because they are very thin-walled.
Yes,
thin wall,
yes.
Right. Excellent. So let's see some images, and maybe based on your initial non-invasive assessment, what does the expert panel think about that case?
Correct. So I'll just
whenever you feel, you can stop and you can.
Yes,
put up
I will ask whenever. Yeah. Thank you, Dr. Mathur. So what I've done is I've gone through. It's a relatively simple case, but this case we used Amulet, and as you realize, in India, Amulet is recently available. We have had ACP for 5 to 7 years, and Dr. Hazra and me, I think we have done quite a lot of ACPs to start with. Then the Watchman became approved, and we used, and now Amulet is available. I think in US soon it will be. US ACP is not available, so you will probably have Amulet. One advantage of ACP, since Dr. Sahil did raise this a question, because in US they have to receive at least short-term Coumadin. They should be a candidate for a short-term Coumadin. But advantage of a ACP or Amulet is you may not need a Coumadin. We just give dual antiplatelet. Unlike warfarin, we may not need a Coumadin. And if you look at evolution registry, I'm sure everybody is aware, 60% patient, even on Watchman, were actually on aspirin. They were not on. That's why we raised the topic of indication. Whole world tells us we need to use when it's contraindicated. But the guidelines and the data is actually on the other side. You need to use, if you are using Watchman, most of the data is when a short-term anticoagulation was actually used. So just summarizing, AF is extremely common, and it's a very common cause of stroke. But we do have, and especially in elderly, and if you follow them up enough, around 2/3 of AF patients will actually, stroke patients will actually have AF. Strokes are worse because the clot is more venous here. The clot actually occurs in LAA appendage, and it's a larger clot, more mortality and more morbidity. We do have a very effective therapy, and if the CHAD-VAS system, which is the current system, if it's more than one, we need to anticoagulate. But the problem is, wherever the CHAD-VAS is higher, you look at the other system, the Haas blood or the bleeding score also is extremely higher. You see that they are mirroring each other. If you put 1 point here, most of the time you end up putting 1 or 2 points there. That means the very patient who is likely to benefit with the blood thinner, like anticoagulation, is also the patient who is likely to bleed more. And short term, many people tolerate. This is, I think, what Dr. Sahil and Dr. Hazra were trying to tell, that it's easy to convince people for short term. But if you talk about long term, especially as they age and as they have more problem, it becomes very difficult. So alternative something is needed and is being searched for a long time. And whatever be the indication, what I can confidently say is all cardiologists and others sitting here, whatever indication you choose, all of us will have at least some patient who require LAA therapy. Indication is up to you. You don't have to extend indication if you're not comfortable, but all of them do require, and even drugs like statin people do stop. Imagine drugs like warfarin. And if you look at the international trials with the direct oral anticoagulant, 25 to 30% people actually didn't take direct oral anticoagulant even in the trial. Hence, it was not the cost which precluded them. For some reason, simply people do not tolerate this therapy for a long time. Now, what is the rationale for alternative? It's believed, we did discuss this in a little time ago, that more than 90% of the patients with non-valvular AF, which means non-MS and non-prosthetic valve, the clot actually is in one area. So technically, if you can safely exclude, I think the key word is safely, which again, I'm very happy Dr. Sahil brought it up, because it's a preventive therapy. It's very important. The safety is of concern. You cannot produce a stroke while doing a procedure to prevent stroke. You cannot afford to have complication. TAVI you could have because it's a very, patient is very symptomatic. Here, we don't make too much change. So we have to be extremely careful with what we do. Now, this is just a slide. I'm not going to go along here. This is just what we were discussing, the data from Europe, which says that, most people who did use this therapy did have a higher CHA2DS2-VASc and contraindication, maybe absolute, maybe relative. Very few it was used as an alternative. But if you look at PREVAIL and PROTECT AF and even FDA indication, it's actually as an alternative in a subgroup of people who do not want to take this therapy. But just to, I'm just repeating this because, when you start a program in your center, first, I think the biggest, the important thing is we need to be convinced. It's a physician reluctance which has led to underutilization of therapy, because most physicians are not convinced about this therapy. So it's very important that we need to understand and we need to be convinced about this therapy. So you could categorize your patients into 5 categories. Obviously, the world over, anybody who has blood will be category number 1 and they will be used. There are also people who have not blood but at high risk, like people with ulcer earlier or people on dual antiplatelet. Most of our patients, end stage CKD, that's one of the very important indication, because no NOAC or DOAC can be used in them, and 1/3 of them have AF. So it's a very important. If you look at your renal patient, most of them will need it. This. Third is actually in people, this is a minority of people, but this is the one which has been studied in international trial as alternative to anticoagulation. Also, which is very important, is a high thrombotic risk. These are the people who have recurrence on anticoagulation. They could be on NOAC, they could be on WARF, but around 3 to 5% people tend to get repeated strokes. These are the people who could need a LAA closure and then continue anticoagulation. We may not be able to withdraw anticoagulation, but 3 to 5%, I mean, all of us do have these patients. They're extremely sick. For some reason, they keep on throwing embolism and they are on optimal anticoagulation. Like, among them, dabigatran 150 milligram BD is the best anticoagulant. But even on that, there are people who tend to have recurrent stroke. People could combine it also with AF ablation, because recurrence on AF ablation is extremely high. But if you at least close the LAA, then at least one problem, which is anticoagulation of them, could actually come out. Now, coming back to this, LAA anatomy. LAA anatomy is extremely variable. It's almost like fingerprint. So each person, people have named it in whatever way they want, probably depending on what food they like or what food they have had. You can call it broccoli or whatever you want to call, chicken wing. But the problem is it is still variable. How much ever you are not given. Unlike, see, in coronary intervention, you have a choice. Angiogram is done. You know what you can touch. You know what you can't touch. And you also know that maybe a month, a year later, I'll be more confident in doing this. But LAA, once you go in, you don't know what anatomy you find, and it's very difficult. if you look at original data of Protect AF, you realize that the procedural success was just 87.5%. You know, it was low during that time. That's because there were a lot of anatomy where they couldn't use Watchman device. But when it came to Protect, the procedural success became 95%. And when it came to, the registry, evolution registry, the success is 98.5%. That means in today's era, whatever device you have, you will be able to close 98.5% of the LAA. That means we have understood it better. We have also understood to accept something more. With Watchman, I'm not going to discuss Watchman too much today. I'm just concentrating on the case which we used Amulet. But at the end, maybe 5 minutes we could take and discuss how Watchman is different from this. But you know, we started accepting more compression, we started accepting more shoulder, and with that we are able to now do more, and also pre-evaluation was done more. So now we are able to do. So now if somebody asks you which is the best device for most anatomy, answer is any device. If you have one on your shelf, you are able to do it in 98.5% of the cases. Now these are the different anatomies which we have, but believe me, when you actually do it, there is no one anatomy. It's all mixture of all this. You just don't know. And in some devices like ACP and Amulet, you just don't have to know what is it. You know, you just don't have to know, because you're going to put a device in the neck. When we are talking about LAA, it's important to understand LAA has two parts, a neck and the body. And they're perpendicular to each other. There are devices which are specific to the body. There are devices which are specific to neck. So among the example which we have commonly, Watchman is more for body and ACP and Amulet is more for neck. So in neck-based devices, depth doesn't matter at all. And in neck-based divided, whether it is cauliflower and midneck, usually doesn't matter. Pre-procedural TE, nowadays actually in our center at least we don't do any TE pre-procedure, we do it just on table. But if I have to go and proctor somewhere, I ask them to do one TE, not for measurement, just to rule out LA clot, because I don't want to fly to that place and come back. I've done it before. So learning from experience, I tell them just before I board the flight, please do one TE and rule out a LA clot. Anatomy and other things don't matter, we can manage. CT is useful, but there are two issues. One, it's not commonly available. The second is patient may be dehydrated. LA is extremely, it's a very thin papery structure, so it can expand slightly, go upsize by 1 to 2 millimeter. So if you're doing a CT, make sure patient is hydrated. That's important. And the devices could vary. Now I want to add this, absence of this. So now I think we have an expert group here, and I would want them to, the measurements. I think we could spend some time on measurement and how to do the measurement, because that is important. It's not very forgiving, upsizing in a Watchman is very forgiving. The rule about Watchman is, if you're in doubt, take the next size. You think, rule is you measure. The measurement I have shown is actually more for Watchman. That means you take a measurement at 0, measurement at 45, 90, and 135. So in all these fours, you need to take a view. The one point I want to tell very clearly right now, it's 2 people procedure. It's not 1 person. Your echocardiographer, a cardiologist, or a sonographer doing echo has to be extremely good. Once they are good, your work is very easy. It is very simple. I'm very lucky in our center. We have our pediatric cardiologist, Dr. Kavya, does wonderful echo, and our procedure time, now we are able to finish in 10 to 15 minutes. But when we started, it used to take 1 hour, because it's more about training yourself. People who do echo also should understand you're doing a therapeutic echo now. Means you're doing an echo where you're guiding an interventionist. It's not like doing any other echo. People are used to TE, but when they have to image LAA, it's difficult. People are very comfortable looking for ASD, so you need to train your echocardiographer. Now, looking at all this measurement, if you're doing Watchman, see now there are 2 anatomy here. There is, let me show the 90 degree. So there is neck, there is body. This is relatively small looking appendage. So if I have to do a ACP Amulet, I would measure the ostium here. and come 10 millimeter in, and this is the circumflex artery, I would measure this number, this one. Okay, so this measurement I would take it in 0, 45, 90, 135. This is what we'll call as a landing zone. But the same case, if I have to do a watchman, then the measurement is what is shown in the picture here. That is that measurement is what is shown. So same appendage, the size or the number which you take is different. That's something which we should understand. So your number is device specific. So for a ACP, the number would be little bigger and it would be here. And for a watchman, the number is here because it's a body-based device and depth is important. The one is what they've taken is an important number. Imagine this for a watchman is say all these numbers are 21, 22. The maximum number is 22. Then you would add 4. So the device will be, it will be 26. And you would take a 27 or a 31 device. You would upsize it significantly. If there is enough depth, I would actually take 31 even for a 21 size because more upsizing is much better for watchman. It confabulates, it molds itself quite well. The peri-device leakishness, and now we know from the data that shouldering is acceptable. Okay, so for the same this one, if I get 21, this particular case, because I don't see a huge depth, I would take 27. But if there was a bigger depth, I would actually take 31. So a lot of upsizing is possible if you would do with the watchman device. More upsize, better, but be a little careful while delivering. We'll come to that later. But if you're using an ACP or an amulet, too much upsize is just not possible. If you ever have a device coming out or pushing out, it will be when you upsize it too much. So then the measurement will be here. And if the size is 21, I would take a 23 or a 25 device. If it is an amulet, it would be 25. If it is ACP, it comes as 22 and 24, and you would take. So 3 to 4 millimeter upsize from the maximum diameter of the landing zone. The landing zone for ACP is one where you measure the ostium, but that's not the landing zone. Come 10 millimeter inside and measure. Initially, first few cases, you need to do it in every case. Later, you have a fair idea where it's going to land, and that's the landing zone. People don't like this landing zone concept because, wherever it lands is the landing zone. How much ever good you are or how much ever you plan it, it just lands where it wants to land. But you need to have a fair idea and measure it. Angiogram is not useful. As interventional cardiologists, we just like giving dye everywhere and we want to see a beautiful picture, but angiogram is not that useful. It is useful when if your communication with your echocardiographer is not that great, or places where you're proctoring, sometimes, you're not able to see. Recently, me and Ravinder, we did one case, that was a video proctoring. It was a very interesting case. We did it recently. Such cases, once you're not able to look at the echo very clearly, one angio gives you a fair idea of what you're doing, but otherwise it is not useful. ACP amulet, the view is RAO cranial because you want to look at the neck, whereas watchman, the view is RAO caudal. That's the view. You need to take both the views, but these are your working views. Now look at this picture, which is a TE image. If you're doing a ACP, the measurement shown is for watchman, but if you're doing ACP, the measurement will be here, 10 millimeter here, and it's here. So all I want to tell you is there is different number you get for different devices. You need to know the device, you need to know the anatomy. And this is again the watchman sheet showing the angiogram of watchman device. Now let's talk a little bit about amulet device and see how we do it. Amulet, it's a bi-lobe, it's a 2-lobe device. It has 2 parts. There is a lobule, there is a disc, very similar to ACP, which most of us have been using in India for a long time. But think about the difference is this comes preloaded. Compared to that, it's available in much bigger sizes, and it's little more forgiving. It's more softer device, so little more forgiving. It has more hooks. You should realize that LAA devices need to have hooks. If they don't have hooks, almost all non-hook devices embolize, and almost all of them have been withdrawn from the market. So you should realize it's not ASD. You don't have a margin here. Most devices do have some sort of a hook. And this is how it looks. It has a lobule, it has a disc, there is a separation, and this is how the disc should, the screw which is there is more retracting in amulet. This is how it should look. Should be wondering, this is more like a pacifier principle. The little tug on the lid which is making it flat is very important. That is the one which holds it, like pacifier. You realize that child can never take out a pacifier. How much ever it sucks, it actually pulls it back. It's on the similar principle here. It's not just two discs which are there. There is a principle. There are also markers on device, and this is the gola shape, which is very, very important. As we are deploying device, we always use this. Now, I always like to emphasize the point that LAA is very thin and very delicate. You need to respect it. That means do not take your sheath inside LAA alone. Sheath is very dangerous. Do not take your dilator, do not take your sheath. It's very, very dangerous. So how do we lead? It should always be led with the pigtail because they are very safe, very soft. Rarely you could lead it with the wire, but little curved wire. Do not, if you curve a wire slightly, we can do it. If Dr. Horst joins, he will tell you he would always lead it with a wire and do it perfectly. But believe me, he's an expert in this field. So when you start, please take the pigtail to lead the area inside. And if not, with the device, if you make this gola and then, with the round shape, and if you start leading it, that's also relatively safe. So do not lead just one with device. So this is how, these are the animal study which shows the relationship between LAA and the relationship between the circumflex artery. You need to know that upper pulmonary ridge is here. The device gets implanted here, and device needs to be slightly compressed. And look at that beautiful concave shape on the device, on the disc. That's something which is needed. It comes in different sizes, more sizes, typically from 16 to 34. But 34 means you can put it in as large as 31 millimeter LAA. Again, it's the landing zone which is important. It's not the ostium we are talking about. It's the landing zone which is little inside, and this is how the device looks. It comes in one uniform size sheath of 14 French. Both Watchman and Amulet comes in 14. ACP comes in 10 and 13 French. You need wire, you need sheath adapter. Usually here, I'll go to the step-by-step, verification. Now, when do you know it's a correct size of device? If it looks like this at the end of deployment, it is correct. That means it's slightly pressed, what we call as a tire shape. There's a good separation between the disc and the lobule, and the disc is concave shape. This is the best size possible. What about this size? Definitely undersized. This could still hold on, but you will see a lot of peri-device leak. And today's era, in current prescription, we do not want any peri-device leak. And look at this. This looks good. This is what we call a strawberry shape. It looks good, but it's not ideal position, because when you have strawberry, the hooks are not released completely. Although it looks, for a coronary intervention, is something tucked like this looks very exciting and very nice, because you think the embolism risk is less, but it's not very ideal because not all hooks are released. We do use it sometimes, especially if the LA is just 11, the smallest device is 16. We need to use it sometimes, but it's better to avoid. So coming back to the case, I think all our experts agree that the best way for this patient is to do a LAA closure. The very important thing is the septal puncture. That's the key. And please understand septal puncture. I know most Indian cardiologists have done enough BMV to think that they can do anything without echo, but it's very important to learn this, because most future interventions are actually TE guided. You don't need a aortic catheter if you are doing it. You just don't need it. Heparin, only venous puncture, that's all is done, no arterial puncture. So the femoral complications are very, very minimal, and it's a precise puncture. So half heparin is actually given. And as Dr. Hazra was telling, with this, we are actually confident of doing procedure even when patient is on anticoagulation, including newer anticoagulation, because you're going to puncture it precisely. So to do that, we need a bicaval view. Okay, so you need an inferior-posterior puncture. To come inferior, you come to bicable view and pull it down. Even if you find a PFO, do not enter through that. Puncture it in lower, inferior-posterior. But as much as possible, it is still thin part of the septum, not the thick part. So once you come down in TE guided, in AP view, you know where it is. You don't need RAO, you don't need LAO, you know where it is. And you can see some tenting which is happening here. And what do? Then you ask the echocardiographer to show a aortic view. When they show aortic view, you have to go away from aorta. Inferior is done here. We need to go posterior. So it is away from aorta. For that, you need to rotate your broken barrow needle clockwise. You remember clockwise here, anti-clockwise later. So clockwise, as you go clockwise, you can see your, the broken barrow tip going away from aorta. You don't pull up and down here, you rotate it, okay? So if you are at this point, a puncture under echo guidance is easy. There are times when it may be difficult, it might start slipping, in which case you could touch the opposite end of the cautery to broken barrow needle. If you do that, it will go easily. Or take a opposite end of coronary wire and through the broken barrow, it goes easily. 014 wire goes easily through broken barrow and puncture the septum. So you can have a precise puncture. As soon as you enter LAA, this is how it looks. As soon as you and this you are doing with your 7 or 8 French mullet sheaths, or you're actually doing it with SL1, any of your catheters. But remember, you're taking both dilator and the sheath, not just the dilator. For BMB, most of us take only dilator. You take both. Once you enter LAA, what you need to do is measure LA pressure, and next give lot of heparin. Do not worry about heparin. Over heparinize. That's the rule here, because these are older patients. They're very thrombotic, and we do not want to produce stroke while doing LAA. So give more heparin, because at the end it's only venous puncture and we can use a figure of 8, so it really doesn't matter how much heparin you give. And this is how LA appendage looks. I am sure most of you can see the ridge of coronary circumflex artery. And if you're doing a ACP, you will do one measurement at the ostium, come 10 millimeter inside and do the second measurement. This measurement is the landing zone, and you need to do it in 0, 45, 90, 135. Take that number, ask your echocardiographer to give that one number, and that number upsize by 2 to 3 millimeter. So if it is 21, you take 24 or 25 device. Too much upsize, as I was discussing, is just not possible here and better to avoid. What do we do after that? So next is to exchange the device you're now with 7 or 8 French sheath, you're in LA, you're optimally anticoagulated. Now you need to exchange it to the sheath, which is 14 French. There are many ways to do that. You could exchange in LA appendage itself, but then be careful with the wire. For beginners, at least first 10 cases, I would advise exchange it in the pulmonary vein. It's very forgiving. So take your catheter to pulmonary vein and exchange it with the super stiff wire. Now take your 14 French sheath, and that sheath now is in pulmonary vein. As it is in pulmonary vein, you can take your device. If you look at this video here, the initially with the bleb was actually in pulmonary vein. I push it out and make a small gola, and then the whole system, as I pull it down, it falls into left atrium. You look at this image, echo is paramount, and look at how beautifully you're actually able to see that gola which we made, that's spherical in LA appendage. And depending on where you want to load, you can load. So if you see here, we know this is the position where I would want it to start. So I don't have to go too deep in. So even if there is a distal muck or this one, I'm not really worried. So I would put it here and start releasing the device under echo guidance, under fluoro guidance. For this, I would go to LA RAO cranial view, because the device is ACP. There are cases we would actually do it in RAO caudal view. Most important point here when you start releasing the device is anti-clockwise. Remember, clockwise there, anti-clockwise. There should be a significant anti-clockwise torque on the sheath completely, and you know the position is this picture, you know the device is here, and then you can see the device slowly getting opened here. From gola it becomes a triangle, and then it becomes a square. So you can slowly seeing it, you know, the triangle is seen, and then it becomes a square. Amulet gives that triangle shape. ACP doesn't. ACP directly from gola becomes a square. So with the amulet, you have the triangle intermediate position, which helps you to adjust your position of the this. So with this triangle, you know where it is. Lots of anti-clockwise torque, and then unsheath the device, not unscrew, unsheath. Hold it and start unsheathing the device. As you do unsheath, you realize the device is formed and the disc is open. At this point, look at the echo again and see how it is. So if you look at here at this point, see, we can see the device opening very well. This is the position which I would want it to be there. And then once I'm very sure this is the position, I unsheath further so that the disc is released. So that's what you see here also. You can see in echo how the device is getting open, and you know, slowly it gets unsheathed. We can feel it holding, and this is how it looks in echo. Look at this shape. It's not a full, there is a compression here. There is good separation. And when I tug, this tug is not a ASD wiggle. It's just a constant pressure which is given. When you tug, you realize that only the disc is moving, the lobule is not moving at all. And you reconfirm the position, you feel that it is good. At this point, if you want, again ask your echocardiographer, where am I? You want this lobule to be predominantly inside circumflex, almost more than 75%, if possible even more. You want the disc to almost completely cover the opening, anatomical opening. You want the device to be slightly compressed, and you do not want any peri-device leak. You know, to look at peri-device leak, it's very important to bring down the Nyquist limit and see that there is no peri-device leak. Today, as I was telling you, current implantation technique needs you to be perfect. As I think all our experts were telling, you cannot afford to have complication. You also have to do a very good job when you're doing a LAA closure. It's not about implanting something and coming out. Once you're very sure, now you look at this echo. I hope all of you are able to see how beautifully the lobule is completely open, and it's completely covering the appendage. It's slightly compressed. LAA is almost excluded, and you see the disc which is almost completely excluding the appendage. If we had taken a smaller size, it would have worked, but it wouldn't have been this good. So you need to take the right size. You need to implant in the right position. If you go too deeper, there could be one of the trabeculated area which is exposed, and that could be the problem for thrombosis. And this is how you could position it here. You also see a left upper pulmonary vein without any flow limitation, and you don't see any flow through device, although Nyquist limit may have to be reduced. But this looks very good. Once it looks good, you have to just release it using a you just unscrew it. So unsheath first and unscrew later. That's what you need to do. With amulet, look for air embolism. LA pressure has to be more than 10, and look for arrhythmia, bleeding. The stroke prevention strategy, so you have to be careful. With this procedure, we realize that the chance of recurrent stroke reduces by 95%, not 0, 95, as much as the newer oral anticoagulants do. If possible, just dual antiplatelet is enough, and it's given for say 6 months. That should be enough. After that, a single antiplatelet. Typically, it endothelializes well. If possible, between 45 to 60 days, just do one more TE and make sure things are fine. Sometime, very rarely, if you look at the registry, around 3 to 4% people did have thrombus on the device. Such patient might require a short-term anticoagulation till it dissolves, but typically long-term anticoagulation is not needed. So I think with this, I'll stop my presentation. We will have some discussion, and there are some questions also, Dr. Mathur.
I was looking at the chat, and there's a lot of discussion going on. Excellent presentation. This is, as you have very clearly spelled out all the steps and what precautions to be taken. I really commend you on such a good presentation today. And now, so maybe we'll take some comments from Dr. Hazra. What is your opinion about this case and the choice of device, and would you do something differently, and how would you do that?
Actually, since I have learned from Ranjan, so it's a great tribute to hear him again. And he's a master in this, but definitely when you start doing, you also learn your own tricks.
Yes.
This LA closer is a job of anybody who is, doing any structural heart disease, septal puncture. And it's a zone of 1 o'clock, your arm from 1 o'clock to the 2:30 a.m. 2.5 hours. So you look at your hour, in your watch. This LA area is playing in that area. You cannot look at 12 o'clock, you cannot look at 4 o'clock. So all these game has to be completed in 1 o'clock to 2:30 o'clock or maximum 3 o'clock. Second, if you, once you're entering a tough septum, sometimes you have to give a anti-clockwise torque to enter into the LA, otherwise you will flip back into the RA.
Dr. Hazra, can you clarify this?
Sir, if you look at the watch, if you look at the watch on angiogram fluoroscopy, this LA appendage is actually from 1 o'clock to 3 o'clock. You have to play in this area only.
On fluoroscopy,
So, on fluoroscopy, on RO caudal, So you have to give an anti-clockwise torque to enter into the LA. Sometimes it works. So you have to see the movement of your ship once you're entering. And it's ACP is much more visible than Watchman. That's the beauty of ACP. It's much more visible. And once you are actually taking the ACP little bit pull, then it drops into the LA appendage. Don't pay too much attention to the posterior inferior all the time. If for the beginners, I would say avoid anterior puncture because that will kill him. Here little bit of posterior here and there or the middle would not be that difficult because you can, though it's not a flexible shape, you can still manage. And you just walk into the LA. Watchman is walking out. You just make an onion ball or meatball, and once you're giving a tug, you see a idli shape. The Indian idli shape, what Ranjan was saying. So once you see that idli shape, and there's separation between the lobe and the disc, is always better to dislodge the device rather than accepting a compromise and embolize later. So give a sufficient tug, satisfy yourself, and rest of the procedure Anjan has described nicely.
Excellent. Sahil, your call. You use different devices, and how would you look at those in this setting?
Yes, so Amulet is not available still, under trial, and it's going to take some time. But that said, we use Watchman. Procedurally, it's a little different, and like you mentioned, it's more a body device more than a neck device. So RAO caudal views, 2 o'clock is mostly where we find the appendage in RAO caudal view, and the key is you go in with your pigtail and you start sheathing. So you cannot push the device in. You basically have to unsheath the device. And I was involved during my training in a conformal device, which is also an interesting concept. But again, this is going to take some time before it comes out. But Watchman is imaging is almost the same. Of course, you measure it lower than where you would measure the ostium and 10 millimeter. You even come lower than that from the limbus to the circumflex. And again, you want your compression ratios. We are very aggressive. We like to have more compression. Previously, when the device came out, was 8 to 20%, but we are more than happy to have more than 20%, 30% compression. We like it. My question is, and Dr. Ranjan, really, this was masterful presentation. I'm really super impressed. You should be at TVT Connect every year giving these talks. There's a lot to learn.
I think you should get him invited there now.
Yeah, absolutely. That was masterful. My question is surveillance. There's a robust amount of data that when you have peri-device leaks more than 5-6 millimeters, even small leaks, the risk of stroke is very high.
Yes.
So what is your strategy for surveillance in these patients?
Correct. I think it's a very interesting, very important question, Dr. Zahir. So I think what we do when, my practice, I think more 50% device is where I proctor and 50% is where I do in my center. So all the cases which we do in our center, we make sure we do a 45 to 60 day TE after that when we follow them up. But as you rightly pointed out, it's see, if you have a leak, it's very important to not to have a leak at all, because if you find it later, there's hardly anything which you can do, and most of them might end up being on anticoagulation. So that means you have risked the patient by doing a procedure, and now you are again continuing anticoagulation. There's hardly anything you can do, people have tried coil and one more device, but they are not really practicable to be done. They may not work. So the way we avoid it probably is very, very important. The way nowadays we make sure that there is no peri-device leak at all, and it's possible to do that. The trick is, one is upsize, second is to make sure you implant the device in the right position. With Watchman, I think trick is just upsize. If you upsize, the chance of peri-device leak will be really negligible. The one more thing is you could be too deep in Watchman. That's something which happens. So you may have to go recapture it and bring it little outward, accept a little more shoulder, and that's how you avoid a peri-device leak. Luckily with ACP and amulet, since you have a double protection, you also have a sheath, you also have a disc which is outside, just like Dr. Yadav was mentioning about Lambre. Lambre also has a similar technique. So you have one more protection outside. So if you tend to have both of them, if you have double protection and with the endothelization, it may be okay to accept the leak peri-device, but because you have one more protection. So we do not have data about ACP and amulet producing any problem when there is a peri-device leak. But with Watchman and the way the Protect AF and Prevail were designed, they were designed to look for these leaks, and they were designed, your treatment strategy would vary depending on whether you have a leak or no. The trick is not to have it, and it's possible. It's possible, Initially, when you start the program, I think your whole focus is on just implanting a device, getting a successful device without complication. But as we do more, you realize you need to do it right, and you can do it right. It's like coronary intervention, no? Initially put a stent, make sure nothing happens, but later you want to optimize it and you want to do it well. So it's possible to do that, provided you take a little more time in sizing the device well.
No, I think that's a great point. The best way to avoid any leaks is not to have a leak when you are happy and satisfied. And do you routinely inject through your sheath? Contrast?
Yeah. We do inject through a sheath at the end, except if there were any renal failure. There are patients where we have done with zero contrast, especially with creatinine 3 and EGFR 20, 30. These are the patients we have done with zero contrast, only echo-based and fluoro-based. But if the renal function is normal, we do inject. But that doesn't give us too much of information in ACP and amulet. Whereas in Watchman, I'm always happy to do an intra injection just to see where I am. And nowadays, more or less, I realize I'm more deeper than I want to be. Initially, there is always a lobe which is way deep in, and which we are able to enter with too much anticoagulation on your, that downward bent lobe can be entered. Most of the time we realize your device is much more inside. So many times we have to recapture and get it back, and giving an injection in between and when you start really helps in Watchman to, optimize it. With the ACP, especially we could get an echo, the kind which I showed you. I mean, that's thanks to my our echocardiographer. She can get such wonderful images. You're very sure where you are opening your device, and where you are positioning it. So one message to everyone is, two of you have to learn. It can't be one person learning this procedure. You have to make sure your sonologist or echocardiographer learns with you very well.
And Watchman, one more thing, don't push it in. Don't push it.
Always pull. Always pull.
Very different. It's very different from this.
Correct.
There's no gola there. I mean, there's only going to be an.
Correct.
Which is the safer device to use in your experience?
I think, yeah.
Amulet.
Dr.
See,
Hazra.
yeah.
Yeah, I think Amulet is the best. Lambry is also coming up. Watchman, though it's it's basically Victorian fight, a Victorian power versus American power for any device.
Yes.
So whatever comes from America is very difficult to enter into the European market. Whatever comes from Europe is very difficult to enter the American market. So it is an ego problem. But I'll tell you, even for Americans, ACP is much simpler to do. Ampli is much simpler to do.
Yeah.
Lambry is cheaper in India.
Okay.
And I think it has some advantage because of ease of implant, multiple lobe occlusions, and definitely cost and large data from China. If you believe Chinese data, okay, Lambry, they have data. And the visibility is very important. Visibility, I would say, Amulet and ACP is the best.
So Sahil, would you like to speak a little about the pitfalls during this procedure and what all wrong can happen? A prolapse of your device or an embolization of your device. What are the precautions we would take? First Sahil, then Ranjan, and then we'll go to Dr. Hazra.
Yeah, I think procedurally transeptal is the key. I mean, it's an anterior structure. We all have to realize that. And the way the sheets are curved, so the best trajectory is inferior posterior entering. So now there are three different, at least for Watchman, there are more sheets available. And even if you have less than an ideal puncture, you can still get your device in. But then the orientation of the device, when you release it, might be canted. So you might have, mostly device displacement, if you will, and it cants to a more neutral position. Very rarely, I mean, we oversize so much, very rarely would you have device embolization, at least for the Watchman. Effusions, yes, when you're starting out, and remember these are very thin. LA is like, it's paper thin, like everyone said. The risk is, especially when you don't have enough depth and you're taking on very challenging cases, you can injure, you can have effusion, and that is sort of what is dreaded, and sometimes they need to be surgically repaired. I mean, you cannot even fix them. So I think effusion is a big problem. Your transeptal needs to be perfect. Otherwise, the devices, the technology has matured so much, and now with Watchman Flex, I mean, even that is not of that big a concern. So, and Amulet is just, it's a phenomenal device. I mean, as Dr. Ranjan showed, it's just an amazing device. It's, once you make that spherical shape, you push it in, it's sort of absolutely zero effusion risk, right? The only effusion risk is with your wire and at that point.
Yes.
So how is the Amulet different from the ACP? What are the differences?
Yeah. So I think there, Dr. Mathur, Amulet comes in much larger sizes. You can go up to 34. Looks almost same, but there are more hooks than ACP. It's a little more softer, so you could be upsizing it a little more. Comes pre-sheath, pre-prepared. Just have to flush it. Just like Watchman, it's pre-loaded. One more difference would actually be when you release it finally, ACP has a hook which is projecting out. Here that hook is little more inward, so it may be less thrombogenic in time to come. It's obviously more expensive in India compared to ACP. The cost is a little higher. But that's something which is going to be there, and most we may have to shift to ACP Amulet completely, because right now ACP is produced only for sake of China, because they use it a lot. Just for India it would have gone up, and Western market is typically only Amulet. Just to add on, I think, to Dr. Hazra, which device is the best, for a technical, I think Dr. Sahil also did add it. For a beginner, Amulet and ACP is definitely better and definitely safer, because it's, it's from outward you're coming in. Technically, no touch technique. You're not going deep in at all. You don't have to go deep in. If you size it properly, it is better. But once you, people who have used Watchman, some of them just can't use Amulet at all, and people who have used Amulet, some of them just can't use Watchman. So because it's so much different. With Watchman, you need to respect LAA a lot because you're deep in. But once you learn to put Watchman, the way it orients, it's self-centering device. The way it orients itself and the way it closes LAA is actually very beautiful actually. At the end of it, when you see, you realize that, you know, you've done a perfect job, much better job with Watchman. So if you, once you overcome the learning curve, Watchman becomes a better device. But initially, it has to be, anybody who starts should probably start with ACP and Amulet. Yeah.
So what is the possibility of a compression of the left circumflex artery, Dr. Hazra, and how do you prevent that?
Yeah, I mean, circumflex will never get compressed, I tell you. Whatever compression you have, 20%. I want to mention about only one complication, not the air, not the thrombus, is the pericardial effusion. For the listeners, I think if you develop, as Kira was mentioning, these effusions are very small effusions. And how do you tackle this? You take this patient on echo, you will see a thin effusion and hypotensive, and you take them on fluoroscopy. Go to left lateral, absolutely left lateral. Take a small micropuncture needle, fill it up with 2 cc series of dye. On your screen, on the left side, there will be sternum, and there will be a wide zone, very thin wide zone of pericardial effusion or pericardial fat. So we are going from the epigastrium towards the left shoulder. Start injecting very small amount of dye. That will be kind of a roadmap. So once your roadmap suddenly enters to the pericardial effusion, you can see the sudden popping or the blowing away of the dye. You not see, that's end of the roadmap, the end of the road. You don't see anything. Basically, the dye has entered the pericardia. Then take this thin wire of the micropuncture needle. Then you exchange with your 5 French sheath or 7 French sheath or pigtail or whatever. Most of the time in the cath lab, you have sufficient time in the cath lab to go for this procedure. It's not like your mitral stenosis or any big rupture like pericardial effusions due to coronary perforation, because this is a high pressure zone. This is small pressure zone. Coronary perfusion, pericardial tamponade will not give you time. Even then, it's better to go to lateral. So in one ward, the juniors must practice puncturing the pericardium in lateral positions rather than AP position. Over to you.
This is like the electrophysiology people. Dr. R.D. Yadav has made a comment that they use it for epicardial ablations, right?
Yes, yes.
So are you comfortable with the length of the micropuncture needle to get to the pericardium? Sometimes the routine puncture needles fall short and are not able to reach the pericardium.
No, sir. It will automatically. Or you take it this spinal cord. I mean, it's
lumbar puncture.
Lumbar puncture. Yeah.
Lumbar puncture.
Or you can take this normal also, but normal needle is much thicker. That's the only problem. But normal needle, you can push the 3-5 wire immediately.
Is thrombus formation on the device a concern or
DRT?
Precautions?
DRT is around 3%. We still do not know the cause. And deep implantation of Watchman is one of the cause. Maybe AF is a disease, I'll tell you. ASDA, postoperative ASDA, behave differently from the A for non-valvular. If they bleed, with or without valvular anticoagulant, they have thrombus formation tendency on any device, and maybe defective endothelializations. Each and every patient, human being is different. So the genetic makeup for thrombosis, genetic makeup for bleeding tendency, all are different. So DRT, device-related thrombosis, or 3% and 13% they go into stroke. So that is the only drawback of having 2B indication or having a electrolyzer device in the appendage. And there's a newer study available from Vivek Reddy, and that is the only point against going for this electrolyzer device, DRT.
So a final comment from you, Sahil, and then to Ranjan. We have done very well with this. We're slightly over 1 hour. And it was such an enthralling discussion, we didn't realize how time has gone. Yes. So, Sahil, your comment, and then we'll go to Ranjan.
Yeah, in effusions, don't forget to reverse your heparin.
Right.
So, if you have a device in place and you see an effusion, just leave the device, get out of the LA, and reverse the heparin. At that point, you can give protamine. But this was an amazing, session. I really enjoyed it. And the key factors are patient selection, optimal device selection for your patient. We do CT routinely. So, we do 3 ways of measurement. One is obviously your TEE at 0.45, your standard views. Then you have your angiography measurement. We are still injecting with the pigtail. we measure, we calibrate and do fluoroscopic measurements. And we also have pre-existing CT measurements for most patients. So there are 3 ways of measuring. But I know things are, we don't do CTs normally, back home.
Yes.
It sometimes gives you more additive information. The CAT scan, it tells you about multilobular, and sometimes you change your lobe entirely where you want to land your device, to cover. But otherwise, this has been a great session. I really enjoyed it.
Thank you, Sahil. And last words from you, Ranjan?
Yeah, thank you, sir. It was, I really enjoyed the interaction here and very well planned. I think one key message, what the way we could do is when we start, respect that septal puncture, because that's important. So even when people are doing a balloon mitral valvotomy, if possible, you start learning step by step, so that at least you could master a septal puncture. Site of puncture is different. You would puncture a mid-septum, but this you could do under TE guided, and nowadays TE is done even without general anesthesia. We are able to do it with DexMed. You could use a pediatric TE probe because the frequency is same. Both the pediatric and adult people tolerate. So try to at least learn the septal puncture so that when you have to do the device, you have mastered some of the steps already. So it's very important to divide your procedure into multiple small steps and master each of them. Like TAVI, whenever you get chance, at least mentor LV and make sure you have measured the gradient, because at least that one procedure is out of picture. So here I think it's most especially the places I proctor, people are not very comfortable doing eco guided septal puncture. They want to do their own way. They want to put their pigtail catheter, and before you realize they've already punctured into LA or somewhere else. So it's very important to learn that aspect, and that can be done even without LA device.
Just two seconds. Yeah, 2 seconds.
Yes. Yeah.
About the fluoroscopy and the TE, if your II is looking at your scalp, it is 0 degree on your TE. If it is looking at your shoulder, it is 45 degree on TE. If it is looking at your liver, right lateral side, it is 90 degree on TE. And if the II or the X-ray II is looking at your groin, that is 135 degree. And to prevent air embolations, always put that back end of your sheath below that genitalia, below your balls.
Excellent. Wonderful. This was indeed a very, we were all spellbound, a very interesting session. Thank you so much, Dr. Ranjan. You've taken out time to share your knowledge and experience with everybody. A lot of people have made active comments, and we have thank all of you for participating actively in this session.